So return to sport is a pretty hot topic for athletes today. The time to return an athlete after an injury seems to be kind of a sweet spot that we try to hit. And the reason is that we want to make sure that the athlete is safe to return, but also that they're, able to return to that highest level of competition. So there's so many things that we need to be considering when we're looking at returning our athletes back to sport, that we just need to make sure we're paying attention to a lot of the different variables that are out there. And of course, this decision can actually be magnified even more if you think about the different variables like level of competition, anywhere from the high school athletes to the professional athletes. And then looking at it from not just the local standpoint, but also around the world. And when you multiply that decision of return to sport by the number of athletes that are competing at that highest level in major competitions, you can see it's a pretty big undertaking. And that's where our next guest, Todd Ellenbecker, comes in. Todd is the head of sports medicine for the ATP World Tour of tennis, where he is managing the physiotherapists and the trainers who travel with the athletes around the world, taking care of those professional tennis players. And then in his spare time, I like to say, he's actually a physiotherapist and a clinical researcher in Scottsdale, Arizona. And I can't tell you how difficult it is to be not just a clinician and a clinical researcher on top of managing these worldwide issues every day, 24 hours a day. A lot, Todd will tell you, traveling all over the world. And so he has a very unique understanding of managing these athletic injuries at the highest level. So I wanted him to come and talk to us a little bit about how he manages those professional athletes, specifically as it relates to taking care of their injuries and returning them to sport. So I've known Todd for over 20 years, and we've authored several books together. Love working with Todd. So I hope that he'll shed some light for you guys on this whole aspect of sports injury management and return to sport. So thanks for joining us today, Todd. I appreciate you taking some time off.
Thanks for asking me, Phil.
Don't mind. Tell us a little bit about yourself, kind of how you got to be where you are now.
So, yeah, thanks for the introduction, Phil, and great to be here and great to have you guys listening about this important topic. So, yeah, I'm a physical therapist. I grew up as a tennis player since the age of 8. My father got me interested in the game of tennis. And so I was going to be a pharmacist initially in school, like my father. And my freshman year in college, I injured my shoulder playing on the college tennis team. And I went to physio, and I thought it was really interesting to see this guy come around, treat my shoulder, tell some jokes. I thought, hey, that's pretty easy. I can do that. I'm going to change my major from pharmacy to physical therapy because I can work with athletes and active people. And so I got my degree in physical therapy and then subsequently a master's degree in exercise physiology from Arizona State. And that's where I did a bit of research in tennis and certainly already when I was in physical therapy school working with George Davies, one of my mentors. I did a study initially with tennis players and looking at the speed of their serve and how it was affected by training their rotator cuff on an isokinetic device. So I kind of from the very early part of my career, I was involved in research, as I know, Phil, you were as well. And so research, clinical education, and then clinical practice kind of became very important to me. And since I love the sport of tennis, I was very fortunate to be mentored by Bill Norris, who at the time was the trainer for the ATP Tour. He was the original sort of grandfather of tennis medicine. And so when I first moved to Arizona, where I took my first job, we had a small tournament, a tennis tournament at the ATP here in Scottsdale. And I wrote to Bill and said, Bill, I'd really be interested in learning from you. And if I could come to the tournament, I'll make ice bags for you. I'll stretch people. I'll do whatever you tell me to do. But if you'd be willing to show me a few things, I'd love to learn a little more about tennis medicine. And so over the next 16 years, I worked the tournament every year and then eventually was offered a position with the ATP to basically work originally with the physiotherapist and kind of coordinate the program. And now currently I'm the vice president of medical services for the ATP. And going back to what you said, Phil, about injuries, I think historically in the sport of tennis, particularly professional tennis, because it is a lot like the traveling circus, meaning 1 week we're in Barcelona, the next week we're in Cincinnati, the next week we may be in Hamburg, Germany. The players travel from place to place to place. And for many years, before internet and before the current GDPR and HIPAA and some of the other limitations that we had to overcome, there wasn't even really a medical chart on these players. It wasn't like playing for the New York Yankees, for example, where the physio worked with the same group of players every week, and he was with them 360 days a year. Our physios and tournament physicians were really with them certain weeks, and then other weeks there'd be other people taking care of them. And we had really no way of keeping track of their injuries because there was no medical chart. The players didn't keep their own chart, and there was no internet-based EMRs like we have today on the tour and have used now since 2012. So very early on, I think tennis medicine and the way we cared for people at tournaments really dealt with triaging their injury. So Phil's a professional tennis player. He would come in, he said, you know what, my patellar tendon is just killing me today. As a physio, I would treat him that day, whatever tournament I'm at. I do as much as I could for Phil. It wasn't really rehab per se, but it was a lot of techniques, stretching, manipulation of the spine, stretching, some maybe submaximal strengthening things, whatever, but just to get him so that he could actually play his next match and move on. And then he would go to the next city. If his patellar tendon was still bothering him, another physio would look at him. And so that's some of the limitation that we have in our sport because it is so nomadic and it's so international. But what I was going to say is that in the last 10 to 15 years, we've gotten much better at preventative medicine on the tour. We've actually started what we call our performance and injury prevention screenings since 2006, where we basically go around multiple times a year and do a battery of musculoskeletal tests to look for things like internal rotation, loss of motion, posterior rotator cuff weakness, core problems with core stability, loss of hip range of motion. And when we see these things, we put them on extended programs that our physios then track and work with through the year, that they can continue to work with the athlete to address those things in a preventative fashion. So I think one trend, Phil, from a sports medicine standpoint was very early on, it was all about triage. And it's still very important. The most important thing is to see a player make sure that he's ready to play his next match, whether that's later today in an hour, or whether it's tomorrow, or whether it's a week from now. We want to get the player back as soon as we can. But what's become more and more important, and certainly more holistic in a way, is to include preventative measures as well as the measures of recovery. We know how important recovery is. And so we're starting to see things like the compression units, cryotherapy, and many of these things start to creep into our world in medical services, where we are providing and overseeing some of the recovery modalities in addition to triage, in addition to preventative medicine. So kind of in a nutshell, I think that's some of the things we've done with injuries historically. Some of the things just in a quick nutshell, upper extremity, we tend to see a lot of overuse, whereas lower body tends to be a bit more traumatic, plantar flexion inversion, ankle sprains, patellar tendonitis, things of that nature that come on perhaps suddenly because of the change in surface and the multi-directional movement patterns that we have in our sport. Whereas upper extremity, we tend to see things that are really primarily overuse, things like rotator cuff tendonitis, medial epicondylitis. Those types of injuries are some of our top injuries in the upper extremity. So upper extremity, a lot of overtraining and overuse. Lower extremity can be somewhat traumatic because of the dramatic movement patterns required in the sport of tennis.
So playing off of the tendinopathies, the acute and the chronic conditions, how does that play into your management, your decision-making on managing something that athlete's going to have throughout the season, or, all the time managing it versus that one you talked about, an acute injury, that triage type situation, not really worried about that. I think we know how we would manage those. How do you keep up with these chronic nagging apathies and itises?
Yeah, and that's $1 million question. And obviously with your background, Phil, you picked up right on that. That's our biggest challenge. Exactly. How do you manage a guy that comes in and says, yeah, I've got some anterior lateral shoulder pain. You ask him, how long's it been going on? Oh, about the last 4 months. And he's standing in front of you and he's got to play in 2 hours. And he says, what can you do to help me? And unlike what I do in the clinic, or all of us would do in the clinic, where we'd say, well, wow, let's have a look at your rotator cuff strength. Let's put you on a Biodex, or let's do handheld dynamometer. Let's get some ER to IR ratios. Let's look at all these things. Let's do a ton of special tests. That's far from what we would do in that instance. What do we do to get him going? You probably mobilize his thoracic spine. You make sure you loosen up his shoulder. You maybe do some pain reduction type things. But ultimately, you're not going to cure that from that standpoint. That's before the match. The key, of course, is then we would put them on a preventative program or a treatment program then with bands and with portable types of things that, Phil, you and I have worked a lot with resistant band, elastic bands and things of that nature that players can travel with, whether it's a small medicine ball, whether it's elastic band, a lightweight. We find that those are the things that then are ongoing, and we have to continue to plan and modulate the exercises for the players, because otherwise that guy will have that for another year and a half. They can't take time off. Time off is money. Right. It's not like football or basketball where they have a guaranteed contract, and whether they're hurt or they're healthy, they continue to get paid. Our players, if they don't play, they don't get paid. And if they don't get paid, they can't pay their coach. They can't pay for some of their other expenses and things of that nature. So it becomes a very, very complex situation. And I think that's where we sort of juggle with triaging and things, like kinesio tape and things that give instant support and some instant gratification. And then on the other hand, say, look, you've got to take these, you got to do these exercises. We've got to do something to improve your intra-rotation range of motion. We got to do something to work on your posterior cuff strength. If it's in the lower body, we got to do something to improve your core so that your patellar tendon doesn't hurt so much, things of that nature. So it's always that balance between dealing with things that are really chronic and ongoing and how you make them good enough to play in the next match, but hopefully move towards treating it to get rid of it so that they don't deal with it their whole career.
Yeah, you've hit on so many great topics that we're talking about in the class, as a matter of fact. And the last thing I really liked, one of the reasons why I thought about you when we talk about managing injuries, it goes exactly to your point. You're dealing with a sport that doesn't have rest. Like, football, you have 7 days. Basketball, you may have twice a week. Baseball, you have every day. Tennis is the same way, although you guys are playing every day, but also if you're not playing, where are you? You're on the plane, right? Mm-hmm. And it's very difficult to manage that athlete that you're dealing with, which my point here is that one size does not fit all when we talk about injury management, and that those little factors that you talked about, if you're not playing, you're not making money. And it's an everyday thing. If you can't get on the plane, you can't go to the next tournament, right? And so those are really important things to remember when we're making our decisions on these athletes in the return to sport. It's more than just, hey, you're stable and all your strength is back, and it goes to that balance. Do return them too fast or, slow them down. And that's another issue that we might pick up on later is, how do you know when to speed someone up? How do you know when to slow someone down beyond just the simple repair or injury that they've had?
Well, you mentioned, Phil, one size doesn't fit all. So, we get this magic question with all the way from our young junior players all the way through professionals, how much should I play? How many tournaments a year is perfect? And if you think about this, definitely, kind of highlighting your concept of one size doesn't fit all. And you're so right. If you're in the top 5 or 10 in the world and you play 10 tournaments a year, a tournament to a top player means they're usually winning almost all the time. Mm-hmm. So if you play 10 tournaments and you win 10 tournaments, the number of matches that you're going to play in is very large. It's 30, 40, 50 matches.
Yeah.
But if you're like me, I found out early in my tennis career that if I wanted to work with elite level tennis players, I needed to become a therapist and treat them, not play against them, because I knew I was going to be one of the best players in the world, certainly. And so if you're like me as a young kid, I would usually lose in the first or second round. So I could play 15 or maybe even 20 tournaments a year because each tournament meant I would play 1 or 2 matches. And that's really not that much overuse. And when you lose early in the week, you have several days of recovery before you have to play the next week. Whereas if you win the tournament the first week, you might get 1 day of rest and you've got to fly to the next city and play. And so one size doesn't fit all, because it's very different if you're a successful player as opposed to a developing player who's maybe coming on early, losing a lot early. That's going to change exactly how we manage them from a sports medicine sense and manage their injuries, quite frankly.
That's fantastic. The recovery aspect you touched on, and we did talk to Dr. McHugh about recovery science. How do you guys use that there? And I know that there's this balance between science and athletic superstitions and things like that. So how do you guys manage that whole recovery thing when we have these recovery tools that aren't as scientifically backed as we would like them to be, but the athletes swear by them? How do you handle those types of things?
So yeah, in general, we have physiologists that we have as consultants. Dr. Mark Kovacs, for example, who's been a great friend to the tour, and somebody that we've consulted with the USTA, with junior players, and the work I do here in the clinic. Our recovery things, as you mentioned, if you look at the literature, there is no one recovery modality that gives you 20 or 30% improvement in recovery time. We're talking about small percentage points. And so you again wisely said some things about superstitions and certainly anecdotal things. They play a bigger role. Athletes say, well, I did that and I won 2 tournaments in a row, so I'm going to keep doing that cold plunge. Even though I'm now in Moscow and it's really cold out, I'm still going to do the cold plunge, because every time I do the cold plunge, I win the tournament. So, sometimes players do stuff because exactly they're superstitious. But the idea is that there are some limited studies that do show things, evidence that things like the cold plunge, things like the intermittent compression units, things like the recovery tights, the garments and stuff. There are some nice studies that do show some modification of lactate and some other parameters, physiologic parameters, with use of these recovery modalities. And so we do couple those on the tour and in junior tournaments as well. And players, some of the newest things are the things like the Nimble and the Hyper Ice and the Theraguns and those types of things that the athletes can do on themselves, all the way from young developing players to patients in the clinic that use that for muscle soreness and treating, delayed onset muscle soreness and things of that nature. And so I think it's, again, another avenue that as a physical therapist, we need to be knowledgeable about the effects and the true scientific benefits of these types of modalities, as well as being able to understand what works for some players and doesn't work for other players, and exactly the timing and utilization of these things to help to enhance their performance. Because ultimately, it's all about enhancing performance, whether there's a nutritional component, whether it's a musculoskeletal component, or in this case, a recovery component, things like those modalities.
I think that the other part of it that we talked about earlier with Dr. McHugh was harm. If they're not really harming you, what's the big deal? It doesn't cost a lot. It doesn't cost a lot of time and money, so even though there may not be this big block of science that says this is going to give you that 20%, bump, if there's no evidence that it's harmful, I think that it's a decision that you're going to have to make. But that goes back to our topic, which is how do you manage these injuries and return them to sport? And I think recovery plays a huge role in it. But I also liked what you were talking about with the preventive programs. You said you did this since 2006. I think I was with you on the very first start of that, as you put
absolutely
together.
A key role in that.
And well, I loved the idea, because back 15 years ago, right? You're looking for the things that lead to a risk of injury. We're going to talk about that in another podcast with Dr. Hewitt, as a matter of fact, with risk reduction. And so when you're looking at these interventions that you want to do for this preventive treatment, which will, again, talk about injury management, essentially down the road, it helps to manage our injuries. What are you looking for in terms of those risk factors? How do you know it's a risk factor? Are there studies that you're using to identify, hey, if I have this, that means I'm at an increased risk for that?
Yeah, so it's a great question, and it goes back to leading up to 2006. I was on the USTA Sports Science Committee, and we had a group of about 20 doctors and scientists that sat around a table and said, we want to put together an instrument or a battery of tests, musculoskeletal tests, that are easy enough to perform, meaning you don't need a lot of massive equipment, because again, tennis is a very, clubs all over the world, and you're one city, another city. It'd be great to say we want to do Biodex tests on everybody, but you're in the middle of a club someplace. You're lucky to have anything to be able to, you're lucky sometimes to have electrical power there to be able to do, let alone a Biodex. So we sat around the table and we came up with what was called the HPP, the High Performance Profile. And it was a series of 10 very simple musculoskeletal tests that were based on research. Some of it, Dr. Hewitt's research in the lower extremity, looking at the jump test, where you jump and you look at the valgus loading of the limb and stuff like that. And others looking at like external rotation weakness, internal rotation range of motion loss in the shoulder, core weakness, weakness of the abdominal musculature. We looked at those types of factors, and we came up with 10 different tests, just for the sake of saying, like, let's keep it simple, something that you can do in about 15 minutes. So when we took it to the ATP rather, my role with the ATP, we knew that we would have a little bit more at the professional level as opposed to elite juniors, that we would have a little more time with the athlete and perhaps could test for even more factors. And so we again looked at the science. And so we added a number of things that we felt were producing the most common injuries that we saw in our sport, in the sport of tennis. And so we came up with this performance and injury prevention profile with ATP. And it was at that time that, based on the science at the time and what injuries we were seeing, that we looked at measuring internal external rotation, range of motion of the shoulder, external rotation, strength at the shoulder, hip internal external rotation, looking for things like FAI and things of that nature. Single leg stability tests, looking for core weakness, Trendelenburg, those kinds. So each of these particular tests, and then as you know well, as you helped with this, our model was basically saying, look, it's not enough to take our athletes and just do a bunch of tests on them. It's not just research. The real challenge is to actually have the testing, get the results, and then give the results back to the player in the form of programs, X, Y, and Z exercises that they would continue to do, but yet the exercises had to be something that they could do independently, that they could do on the road. And so that's when, in your former life, Phil, it came to TheraBand and the great products they have there that you helped me with, saying these are perfect types of products for people, small little medicine balls, small little pieces of band and tubings and things of that nature that they could travel around the world with and do specific exercises. So the model was find the deficit, put a program together that addressed the deficit, and then the last stage of it was to retest to see if they actually got better once they did the exercises. And like everybody, people aren't as compliant as they should be. And we found that when we retested people, while they did improve, we needed to remind them and give them more stimulating exercises to keep them interested, to get them to keep going the program. So it was really that model that I think led to the success. And we've done over 300 of these evaluations over this time period on specific players that gave us a really good data profile, which we've published in a few places, that gives some good normative and descriptive data on what a tennis player should have. How strong should they be? How much motion should they have? Things of that nature.
So you're using science, you're using data, you're not just basing your decisions, on this one thing that you feel, oh, this is a good or bad thing. I mean, you're actually using the science and you're making it, what I love about it's very practical, right? It's exactly what you said. We sat around, we said, this program has to be portable, has to be self-driven. But the compliance obviously is the hardest part. So you can lead the horse to water, right?
Right.
And when it comes to athletes trying to take care of themselves, I think that they'll jump more to the gadgets and the crazy little things that are easy to do compared to, the basics of let's stretch, let's strengthen. They want to do all that fancy stuff. But I think that on that level though, and probably working with the professional athletes, they're a little bit more into the basics, working with athletes, like Drew Brees, he will just concentrate just on the very basics and not get all, sideways with all these new trends and things like that, and focus is really on the basics. And I'm pretty sure that professional tennis players tend to be that way. And then you having the support obviously makes that happen with your network. So how many physios and trainers do you really have all around the world basically doing this with you?
So with the ATP, which is the men's side of professional tennis, we have 25 physios. Every single one is a physiotherapist.
Wow.
In the old days, like I said, Bill Norris is an athletic trainer. And as the profession of tennis medicine kind of evolved, there was, particularly because of all the heavy European influence, there was much more manual therapy and manipulative therapy that needed to be in the skill set. And so that's how things gravitated from solely a specific athletic training background to a physiotherapist, because of the degree of manual therapy and some of that worldwide that physios have. And so that's how in today's time, at least on the ATP Tour and also on the WGA, which is the women's side, all of the providers are physiotherapists. Now, athletic trainers still play an important role, and we work with athletic trainers in many of our cities. Although I will say, as an international sport, outside of the US, the athletic trainer is not as recognized. There aren't really athletic trainers in most countries in Europe, for example, or throughout Asia, as you know, because you travel worldwide, Phil. The trainer is sort of a unique outside the US kind of thing. It can be really variable. Whereas a physiotherapist or physical therapist, that's pretty steady from a curriculum standpoint, whether you're in Australia or in Asia or Europe or wherever around the world. So we're now physiotherapist based. There is a great deal of emphasis on manipulation and manual therapy. There also is a fair component on dry needling, and some of that is that's gained a lot of popularity with players, particularly European-based players and whatnot, but almost everybody now. And so our sport is kind of evolved in ATP physios providing care along with then physicians at each tournament, oftentimes an orthopedic physician, sometimes it's an emergency-based physician, but they're what are called a tournament physician that basically runs the medical side and assist the physios at our tournaments. And so we have that ability, in addition to an ambulance for emergency medicine and sort of triaging, we have that component at every tournament on the ATP Tour.
Wow. So, and you're coordinating all of that, and that's just
yes. Well, I mean, with ATP Medical Service, absolutely. So that with each
yeah.
tournament, then we're coordinating that, and our guys are, like I said, very understanding. They travel all over the world. They're some of the most flexible guys that'll go from tournament to tournament to tournament in multiple countries, and their passports are virtually filled with going from one place to the other, and managing all different levels of. The sites. Some tournament sites have wonderful training rooms. Some have very primitive ones, but they still provide the challenges. They provide the same great service everywhere they are in the world. So it's a little different again than like basketball. If you're the Philadelphia 76ers, you're working most of the time out of a really state-of-the-art facility in your home. If at least 50% of the games are at home and your training days are at home, that's just a very different part as opposed to, hey, I'm at this facility this week and then I go to a completely different facility in another country another week. So there are challenges, but our guys have been, just the best in the world at dealing with that.
And then how did COVID then impact all of that stuff? On top of that, what were some of the challenges that you saw last year or into this?
Well, just enormous in that it actually shut down the tour. So we ended up having to shut down the tour last March, and we were essentially off until the middle of August. And so there were actually no tour events. So, I mean, talk about a challenge. We went from players not playing, having no direction. They're all sitting in their own cities. So we had outreach through our physios, contacting players through Zoom and other types of virtual methods, getting them training programs and things like that. And then obviously during that time, we had several months to be able to develop what's now our COVID protocol, which involves several levels of COVID mitigation, things like testing, PCR testing originally, and now antigen-based testing. We worked really closely with a dear friend of mine, Dr. Babette Pleim from the Netherlands, who's an infectious disease and public health specialist. And a brilliant physician who guided us from the infectious disease side to put our protocol together, coupling our testing with things like mitigation through physical distancing, mask use, hand sanitization. How do you get a couple hundred people at a tournament to stay apart from one another, keep themselves masked and not spreading a virus if somebody does have it? It was an enormous challenge, but fortunately we've been able to have literally over 100 events now and very few positive tests. When you look at what kind of community, how much spread there is in the community, we're much less than the community so far, knock wood. So we've been very, very thankful that the COVID mitigation has gone as well as it has. And fortunately, none of our players have had serious issues with COVID, and they've recovered 100%, which is great to see. And that's the ultimate most important thing. So.
Yes. So getting back to our topic of the return to sport, I'm curious about, you had these guys off for such a period of time, hopefully working out on their own. How was that return to sport? Not after the injury, but after, and not having COVID necessarily, but after being off for that amount of time and not playing, how does that affect that athlete returning to their sport?
Absolutely. We were, very cognizant that there were going to be a lot of overuse injuries, hopefully no career-threatening injuries, because if when the NFL had a shutdown, I believe it was 2008, there was some data after that with Achilles tendon ruptures that there was a substantial increase in the number of Achilles ruptures and really serious lower body injuries after the work stoppage. When they came back, they weren't able to have that normal, start to their season, the normal training camps and the things that lead up to it. And so same thing for us. We didn't have any kind of organized training camps or anything. We never do. I mean, they're all the players are independent contractors. So our big concern was that they would come back and have, career threatening injuries. And fortunately for us, that did not happen, but we were very busy. We did log a lot of different injuries, but fortunately they were more overuse types of injuries getting back. And so we were very cognizant of, getting players on training programs prior to them coming back. Fortunately, most players have their own group or team of either physios or trainers, strength and conditioning professionals that work with them. And we encourage them to be sure that they were indeed fit and that they could do these types of things prior to coming back to the tour. So, but that was one of our biggest concerns because, we didn't want to see catastrophic injuries upon their return.
What do you think as we wind down here a little bit? We've been talking about return to sport, injury management. What do you think's what research do we need to be looking at to help us make better decisions on return to sport? I mean, you mentioned like the follow-up retrospective of the Achilles injuries. Are there other things, and not about that topic specifically, but in how we manage the athlete returning to sport? We've talked about accelerated rehab, those types of things. What else do we need to be looking at from a research perspective, you think?
Phil, it's something you and I have been saying for 30 years. We need research. And honestly, I mean, now I know that's a general question, but we just have to have research. And I'm primarily work in the upper extremity. I do most of my research and work in the shoulder. And the shoulder is far behind the knee. When you look at Tim Hewitt and some of the great things he and his team have done, and people around the world, the Scandinavians, for example, and many in the sport of soccer, perhaps that probably are some of the more advanced on return to sport and hamstring injuries, ACL, some things of that nature. We're way behind in the shoulder. And so, obviously I've been schooled through Davies and my mentors to be as objectively based with my return to sport decisions, meaning I try to get everybody an isokinetic test. If they can't isokinetic test, do a handheld dynamometer test, measure goniometric range of motion, look at different parameters of functional performance, all of those kinds of things to try to wrap it together. And we obviously just need more research to be able to tell us what degree of predictive value do any of these parameters have. They might have absolutely none. We look at Byram's study from a couple of years ago where he looked at professional baseball players and did a handheld dynamometer test for internal and external rotation and looked at their strength and then followed them up for a season. This was not injured people. These were healthy people to see who suffered injuries. And they found that the most important parameter for professional baseball player was the ER to IR, or external to internal rotation strength ratio. We've known for years that should sit somewhere between 65 to 75, 66 to 75%. And if there's a low ratio, meaning they're overly developed internally or in the anterior aspect, that leaves them suspect for injury because they're all acceleration and no deceleration. So studies like that show the ER to IR ratio in those individuals was the most predictive risk factor. Help us to know in rehabilitation then to be sure that we're not putting our shoulder patients after surgery or after significant injury back with an ER-IR muscle imbalance. Ellen Shanley, Kevin Wilk, and others have done some nice prospective studies to look at internal external rotation range of motion. And that's where the whole GERD concept came, where internal rotation range of motion loss, horizontal adduction range of motion loss, and even ER range of motion loss were really looked at critically to see how predictive they would be at setting somebody up for an injury. And so I think we just have to continue to extrapolate that to our post-operative cases, our labor repairs, our rotator cuff repairs, things that, those types of cases, to be able to determine which of these objective parameters can we measure clinically, and what do we have? Historically, Phil, what have we used? Oh, you got to have your strength equal to the 20% of the, 20% equal to the opposite side. Where did the 20% come? What study? It doesn't exist in the upper extremity. I'm actually doing a literature search right now for Biodex on that important topic, and it doesn't exist. I mean, so everything really, we're talking about level 5 evidence when you go back to where that started. Now, fortunately, some of the lower body studies have actually shown around 20% is a good number as they're finding, but that was all anecdotal at the beginning from our key leaders, the people that have been leaders in sports physical therapy through the years. Our mentors, Phil, were the people that kind of put that out there, and it's kind of stood the test of time for the lower body. But the upper body, like I said, there are no real values there. There's no research that says, you know what, if you're within 10% of your contralateral side, you won't suffer an injury. You're safe. Versus if you're 15%, that's when you're really vulnerable to have an injury. So back to your question, it's just more research, and that's the reason we have to have clinical and scientific based research, basic science research. We just need more of it.
Well, Todd, you've been a mentor to me on getting research out there constantly. You're one of the few in the world that actually is what I call a clinical researcher. You're working in the clinic with patients. You're not out there measuring college students, which we see too much of. That is really not practical for what we need. We need more of the athletes that you have access to. So I just want to thank you for continuing to do that. And as I wrap up, I want to go back to the very beginning of this talk, because you hit on a lot of, I told you at the very beginning, you hit on a lot of great things. Talking about mentors, like George Davies, and reaching out to people like Bill Norris. You don't know Bill, but you know what you want to do. What do? Well, you sent them a letter back in the old days.
On yellow memo paper. That's how far back it was. It was handwritten. I didn't even type it. I just handwrote it.
Remember the old typewriter?
Oh, sure. Yeah.
But I even remember when I first met you or George Davies as a young therapist. Remember how I met you? I just saw you in the hall and I said, "Hey, Todd, I'm Phil. Nice to meet you."
Yep.
Same thing I did with George. George, I'm Phil. Nice to meet you. And what I try to instill in these young people is, in this industry is a small world that really depends on the network that we have internally, and that you can't just get there on your laurels, or get good grades in school and make all A's and think that you're going to be the best sports therapist in the world. You're not. And if you think that you're going to be working 9 to 5 and be a sports physical therapist, that's not going to happen either. It is as you know, it's a 24-hour day job for you, right? But what I want people to take from this is to see where you are in your career, way up here. And I know you feel like you're not, but I know you are. You're way up there where people aspire to be. And you didn't get there just by knowing somebody or by getting good grades in PT school. You did it from hard work. And that's what being a great therapist or a great person really is all about. And you don't stop. You keep going. You have not rested on your laurels. You have continued. We talked about it before this. You want to know about statistics. Who wants to know about statistics?
I do.
I do. More about statistics besides you and me, right?
We're the only ones, Phil.
We're the only ones that want to learn about statistics, because that's what we do. So anything else you want to add, Todd? This has been fantastic.
Just fantastic and follow up. Thanks so much for asking me to do this. And, the topic of mentorship, we could talk about this for hours, but you and I have had just unbelievable mentors. And, and you think in some ways I consider myself to be like Forrest Gump, one of the luckiest guys out there that I had. I could have gone to PT school at a lot of different places or ended up someplace for physical therapy school, but gosh darn it, I ended up at UW La Crosse, and here's this guy, George Davies, who's one of the best in the world. And he took me under his wing and paid attention to me and gave me the opportunities to learn what I know today. And we're still working on projects today and doing talks together and everything. And he, Janet Sobel, who trained me on the upper extremity, and Bill Norris, as I mentioned. I mean, there's just mentor after mentor. And I would throw out to the people on this podcast, if they get access to the ISAKOS journal, it's a journal of a society. ISAKOS is a society. The most recent journal has a great article on mentorship by one of my mentors, Dr. Per Renström, a dear friend and mentor from Stockholm, Sweden. And Dr. Renström, in a group of about 5 or 6 people, wrote this article about what Phil just said. And Phil says a lot of really, really smart things, and he speaks from the heart. And he's, I've always known Phil and loved working with Phil for many, many years now. We both have really, really benefited from the people that are around us. It's not all about Phil. It's not all about Todd. It's clearly all about the people we've been just so fortunate to have teach us things, show us things, give us an opportunity to do these. And that'll happen for everybody on this call or everybody on this podcast. If you seek it, it's there. And so, again, there's a nice article in that ISAKOS journal. It's would be the May issue of ISAKOS, and Dr. Per Renström is one of the authors. and just very good. It talks about how everyone is benefited through their career and how difficult sometimes it is to find really good clinical mentorship and teaching, but they're out there. And if Phil and I can find it, you all can find it too, right? So
That's right.
very good. Well, thanks so much, Phil. I really appreciate it. I really enjoyed this. And thanks for asking me to do it. Have a great day.
All right, Todd. Thanks, everybody. Thanks for joining us. Take care. Have a good day. Bye-bye.